First of all, I would like to thank the organizers, particularly Dr. Saukat Sadikot, for inviting me to this meeting. It was a great meeting, and I think I have come to Chennai many times before, but I think this is the first time I talk to the diabetic audience, diabetic specialist audience in Chennai. What I'm going to talk about is something to do with our current obsession looking at markers for diabetic complications, particularly nephropathy. I think I start a slide with that, where the common question asked by our patient, what do our patients ask when we come to the clinic? The point of care question. They ask, what is my chance of getting kidney disease, like my father who is on dialysis? So I think that is a very pertinent question a lot of us are entangled with sometimes, but we can't tell them. Maybe your diabetes control, your blood sugar, HbA1c, and so on and so on. But I think I'm getting the scenario from the point of care clinic environment, and how do we relate to our patients at that point of time. All right. For Malaysia, just at epidemiology, diabetes in Malaysia is keeping to the prediction by WHO, IDF, Paul Zimet, and Hilary King's prediction by 2020, the epicenter of diabetes is in the Western Pacific area. And Malaysia is keeping to that promise. If we look at the prevalence of diabetes, type 2 diabetes I'm talking about, maybe in 2011, at the National Health and Morbidity Survey, at that time, it's already 20%. But actually now, we will do the repeat survey in 2016, which is 10 years after the last big survey, we will be around 25%. That is already predicted, and I think that will just be confirmed. And if we look at the number of people with impaired glucose tolerance, obesity in the country is great. And I think the number of people with diabetes nephropathy is also quite great. If you look at the number of dialysis patients, among 30,000 dialysis patients, 61% of them are diabetic patients. And that is a very grave concern about the burden of care in years to come. So I think what I'm concentrating is on at the present point of time. What is our indices or parameters we use, clinical parameters we use in telling ourselves about the status of our patient with regards to diabetes care and nephropathy? We have HbA1c, creatinine, eGFR, the estimated GFR, microalbuminuria, and albumin-creatinine ratio. That is the usual thing that we do in the clinic. But in a setting like what I have here, this is a clinic setting, a community clinic setting. In the middle of Kuala Lumpur, you can see the marker there, that's the Kuala Lumpur Tower. And in the middle of Kuala Lumpur, in the clinic setting, seldom do they do microalbuminuria. And microalbuminuria may be selected type of patient who can go home and bring back do their urine and bring back early in the morning. But I think majority of our patients in the clinic setting, point of care, do not do such things. Now, if we look at the HbA1c, the HbA1c in our patients, majority of our patients in the country, the average HbA1c is 9.5%. All the clinics, both in the government sector as well in the private sector, the main HbA1c is 9.5%. And if you look at the male and female distribution, there's no significant there's no significant difference between the male and female. But what is more important, I think, is to look at this is a normal range, but majority of our patients are not controlled. Now, what is more interesting is to look at the duration of diabetes, eGFR, we look at the eGFR above 90, above 60, for example, here it's normal, and here is low eGFR. And you look at the duration of diabetes, a lot of our patients are still early in the diabetes, but and their eGFR is still fit to be normal, and there's no differences. We look at here, duration of diabetes and serum creatinine. Again, majority of our patients, we look at here, majority of our patients still will have normal creatinine, and even though the diabetes may be quite 25 years. So I think you can use those parameters to determine predictability of nephropathy. If you look at the HbA1c here, HbA1c with eGFR, again, there's no significant correlation between eGFR and HbA1c. So what we have done is to look at other parameters. The question here, again, which I raised up earlier about what are the parameters to look at. We are looking at nephrin and CYP2. First, we look at nephrin. Nephrin is actually the protein of the food processes of the podocytes, and it is continuously shedded off in the tubular, and in the urine you get nephrin positive, but it's negative in the serum. It should be negative in the serum in normal people. But if you look at nephrin, there are many things that we need to talk about, but I think because of time constraint, I will just concentrate on a few issues. Now, that is nephrin in the food processes, forms as the filter for all the various metabolites that go through the glomeruli. All right, that's the nephrin molecule. We have already cloned the nephrin. We can know the various aspects of that nephrin molecule and can identify them. And we are currently developing monoclonal antibodies to various parts of the nephrin and try to identify them both in the urine and in the serum. But what's more important here to look at is that nephrinuria is in 54% of normal albumic patients, diabetes patients. Normal albumic diabetic patients already has nephrinuria. And structural damage epithelial podocytes may lead to shedding of, may lead to tubular reabsorption of the nephrin. And that's what we are measuring in the serum. So if you look at this slide, the measurement of the nephrin, this is a number of patients. This is control, urine, and serum. Blue is positive, red is negative. So in a serum of a control should be negative. But if we look at the pre-diabetic patients, some of the pre-diabetic people already has nephrin positive in their serum. Talking about serum, right? Now, the pre-diabetics are those people with impaired glucose tolerance, impaired fasting glucose, and strong family history of diabetes. They are not diabetic yet from the point of view of biochemical criteria. So, but if you look at the type 2 diabetes, established type 2 diabetes, there are some people still negative there, but majority in the serum already positive. If we look at more detail about the established diabetes, we look at those with early diabetes, less than 5 years. This is with nephropathy. All of them in the serum has positive nephrin already. So we look at, this is a patients with diabetic patients, control, and pre-diabetes, and type 2 diabetes. You can see that the control is negative. And this is the actual serum nephrin measurement. And we look at in established diabetic patients, look at those with microalbuminuria and macroalbuminuria. What is more worrying is that those supposedly normal albumin, negative albumin in urine, no microalbuminuria, there has nephrin in the serum. All right, I think I just skipped that. If we look at the individual patients that we have, because these are patients from the clinic, individual patients, there are some patients with HbA1c 6 to 8. These are the red ones, with actually what you call that level of nephrin quite high. But when they develop HbA1c more than 8, a lot of them are old chronic diabetes, very poorly controlled. Their nephrin levels in the serum begin to drop. What we are seeing at the moment, we must look at those people who are early diabetes, pre-diabetic, and use that as our indicator for looking at the potential nephropathic patients. The second marker that we are looking at the moment is CYP2E. CYP2E is actually cytochrome P450 and the subset 2E1. And that is a very important data that have been shown in the international literature about their significance in renal patients, particularly in the diabetic community. However, the CYP1 2E elevation profile correlates progression of disease. It's not been documented, and we would like to look at this in more detail. What we have done is look at the microarray series of all the patients, and we're looking at the development, the early upregulation of some of the pathways, and we look at CYP2E and some of the other components in the polyol pathway, the xenobiotic pathway, and look at the other. The green here means downregulated, non-diabetic nephropathy. Diabetic nephropathy are upregulated, and in control, completely downregulated. So in other words, it's an important indicator for us to look at further for CYP2E. So we have gone through some comparison. What we have done is actually CYP2E from lymphocytes. We take away the lymphocytes and do the CYP2E on them. In the study cohort here, control diabetic patients, and this is diabetic without nephropathy, diabetic with nephropathy, non-diabetic nephropathy, like hypertensive nephropathy. We look at, more important here, is between the cohort, the control cohort, without significant level of CYP2E. Right, and then here in patients with diabetic patients, various HbA1c and the positivity of the CYP2E in them. And we look at another representation, percentage of diabetic cohort patients with presence of CYP2E in normal creatinine, with normal creatinine, 66%, with normal GFR, 64%. In other words, a significant members of the diabetic cohorts with normal parameters, clinical parameters that we have in the clinic, have significant CYP2E. So in other words, I think we need to look further detail about this and do more work on these aspects. You know? Again, comparison with albumin creatinine ratio in all the same cohort, and we look at, again, the significance difference between the control and the diabetic patients. Now, if we look at what are the basis of this, what is the basis of that? If we look at this flow chart about diabetic nephropathy pathogenesis, we look at hyperglycemia causing mitochondrial disease, mitochondrial dysfunction, and that is when the lymphocytes start to be upregulated to produce the various enzymes. Then that is actually making the reactive oxygen system be more activity, and then you get a lot of oxygen or a lot of stress in the tissue. This tissue stress is what is causing the damage. Now, further to look down here, if you further down, then you will get structural damage. This is already morphological structural damage, but if you look at backwards, what we're interested in to look at before structural damage, we must look at indicators around this region and see how it relates to blood sugar and how it relates to other clinical parameters. And if these clinical parameters do not relate to this activity, that means we must look at in more detail and see whether the new parameters and new markers are good for clinical prediction of people who are going to get diabetic nephropathy. As you all know, the diabetic community are very heterogeneous. Some patients are very well controlled, yet they got nephropathy. Some patients very badly controlled, very badly controlled. We have always got to change their therapeutic regime, and yet there's no nephropathy. So I think there are ways, to look at this in more detail. So I think, in essence, hypoglycemia causes a lot of, at fasting glucose more than 5.6 millimoles. Is that a good indicator of good control? I think a lot of us are going to argue on that. But I think what is more important, the relationship of hyperglycemia, at what level it is, causing abnormality at the tissue. And the overproduction of ROS, or oxidative stress, is the key to the pathogenesis of nephropathy. And I think glycemic control itself does not exclude onset of nephropathy. So I think we have a lot of other data to show in UKPDS and so on. But I think just to emphasize the fact that the diabetic patients, being early or late or at point of diagnosis, is heterogeneous. So I think it's good for us to try and get them to be sorted out early, see whether they are in one area of prediction or the other area of prediction. In conclusion, the findings of the study confirm that CYP2E and, sorry, oh gosh, can you prepare? I think you just jumped my slide. Go to the last slide, please. Last one, 34. Thank you. Yeah, if you look at this, we say that in conclusion, the findings, the study confirmed that lymphocytes, CYP2 and nephrin are possible early predictors of diabetes nephropathy because of their upregulations very early on and the gene expression very early on in the cascade of biochemical changes in the patients. And I think what we have to do more is actually to get more sample and do a longitudinal study to look at the progression from control, from normal to pre-diabetes and overt diabetes. And these are some of my colleagues who have been doing the work, my PhD students, and Zaini and Anuar, and one or two more is not here in the group. Thank you very much.
Thank you very much.